10 till 2. I think we're about 50 minutes late here, so we need to get started. First, I'm going to ask Councilor Don Garvin to give the invocation.
Please stand. Our Father in heaven, we thank you for this day. We thank you for this time we could meet and do the business for the Cherokees. We ask now that you would bless each one that's here today, especially our visitors. Be with our country and bless our nation. Forgive us of our sins. In Jesus' name I pray. Amen.
Amen. Ms. Shelley, will you call the roll, please?
Ma'am. Janelle Fulbright.
Present.
Dick Light.
Here.
Jack Baker.
Here.
Joe Bird.
Honey.
Julia Coates.
Here.
Jody Fishinghop.
Here.
John Garvin.
Honey,
Tana Corey Jordan.
Present.
Frankie Hargis.
Present.
Lee Keener. Curtis Snell. David Thornton. David Walkingstick.
Honey.
Kara Cowan Watts. We do have a quorum.
Thank you. The chair will, yes,
Madam Chair,
yes.
I'd like to make a motion to add Councilors Harley Buzzard, Janice Taylor to the committee.
Second. Okay, we have a motion on the floor to add 2 new counselors. Yes.
I'd like to introduce someone in the audience, if it's proper, Representative Arthur Tolbert from Fort Gibson. Good to have you today.
Thank you. Okay, we have a motion and a second to add these 2 new council members to this committee. All in favor, let it be known by saying aye. Aye. Any opposed? Passed. So welcome new council members, Harley Buzzard and Janice Taylor. And the chair will entertain a motion for approval of minutes.
I make a motion to be approved.
Second.
We have a motion and a second. All those in favor of approving the minutes of the meeting, let it be known by saying aye. Aye. Any opposed? Minutes are approved. Next are reports. We have Claire Moore, Mr. George Valyers.
Good afternoon.
Good afternoon.
Well, to eat at Claremore, we've got our report in. You can see we still have an opening for the clinical director's position. That job has been announced and advertised and will close this Friday. Also on that same note, we have a Dr. Stephen Sanders is going to come over from Pawnee and fill in as the acting clinical director until we can get through the system and get a clinical director hired. We've hired several contractors to cover the emergency room and the internal medicine side and the day shift hospitalists, so we're back and covered all the way around now. Visits are up. I called and asked about the MRI. And what I was told by area office is that the requests for bids for the modular building are out on the street. They didn't give me a date of expiration for that. So, but I'm told that that's out for bid, so I can assume that we are moving forward on that, however slowly it might be. Chair, any questions?
Anyone have any questions, comments?
George, when does guarantee start on that machine? I mean, most of them come with a warranty. Is it when you put it in place?
It won't start, ma'am, until it's built and delivered.
So y'all just don't have it there or wait
No.
to put it somewhere?
No, it's never been built or delivered yet.
Okay.
Councilor Keener, you're next.
Thank you, Madam Chair. Congratulations on your diabetic award,
Oh, thank you.
2012. That's,
Forgot to mention it, yes.
you want to say anything else about that?
No, I've got a great crew up there on that diabetic group.
Yes, sure do. And I know it affects our population, though in a negative way. So I'm really glad of all your efforts on that.
Thank you. I'll pass that on to them.
Yes, thank you. Thank you, Madam Chair.
Anyone else? Counselor
How long
Buzzard?
would it take to build that once it's put in? So,
I was told that once we started the groundwork there, back there on the building, that they could have it in 120 days.
sooner the better.
Yes, yes,
Thank
sir.
you.
Yes, sir.
Any other questions or comments? Not, thank you for that wonderful report. Next, Ms. Connie Davis, Cherokee Nation Health Services. She's always got a lot of interesting things to share with us, so
I do.
we're anxious to hear.
Well, I'm anxious to share it. Good afternoon.
Good afternoon.
Just this past Thursday or Friday, I received an email from Rebecca Loving in the Oklahoma City area office notifying me that several of our clinics had been chosen by the Indian Health Service to be recognized for their due diligence in, let me get my notes here, vaccination of our healthcare and employees. And having been in a position to try and encourage that, that is a pretty strong endeavor. But the following clinics received 90% vaccination coverage for their healthcare workers and will be recognized at a ceremony in Rockville on October the 4th. Those clinics are Wilma Mankiller, the Bartlesville Health Clinic, Three Rivers Health Center, Redbird Smith Health Center, and Sam Hyder Community Care. So, and I will have to tell you that falls a lot on the nursing leadership to push that through, the public health nurses, so they're to be commended for a good job. The Hastings OR continues to see marked improvements in their access and quality. The wait list for colonoscopies that you've heard me talk about repeatedly has completely been eliminated, so there are no patients waiting for a colonoscopy. And again, I can't emphasize the work on behalf of Dr. Ballou and Dr. Fishing Hawk and the nursing staff to whittle that wait list of 1,800 patients down to nothing. So that's a great accomplishment. We did 416 surgical cases in the month of August. And another big effort was they received 100% compliance on their SCIP measures, SCIP. And what that is Surgical Care Improvement Project. And these are standards, quality standards set by CMS on how we're supposed to take care of patients. So our patients are receiving good surgical services. So another thing to toot our horn about. The PACE program has received notice that CMS has approved expanding our program or our services to the following zip codes. In Adair County, Watts, 74964, Westfield, 74965, Stillwell, 74960, and Proctor, 74457. In Mays County, Salina, 74365, Muskogee County, the west side of Muskogee, 74401 and 02, and in OK, 74446, and the P.O. Box for Braggs. So what that means is we were limited by zip code on the patients we could see at the PACE program here in Tahlequah. We can now open those services up to all the patients in those counties for service. We'll be able to market those locations after we receive the official letter from CMS, and we expect that to be, and then we can enroll them after November the 1st of this year. They currently have, the PACE program has 120 patients receiving service. The home health has 131 patients. Last year at this time they saw 121. Our outreach program has 567 patients. Last year at this time 351. And we currently have 19 hospice patients. And just a note on the financials for the home health and hospice service. In 2012, we made $11,703. And year to date just now, and that's up to June as far as our board reporting, we are in the black, $146,000. So those programs have really turned around. Mr. Holbert's here. He's with Access to Health. You've heard me talking about he's looking at our revenue, our billing and collections, and finding lots of room for improvement. He found that 41 providers in our system do not have their Medicare Part B number, and that impacts our ability to bill things like physical therapy if it's ordered. And in the last 45 days, since he's implemented some scorecards, we call them, we've noted significant improvements in 8 out of the 9 therapists that we've been working with. We still have lots of room for improvement, but what this equates to is a 12 to 86% improvement in access for our patients, and then opportunities to bill for those services in turn. So this is a great endeavor, and we're glad he's here to help us out. The deed to Redbird Smith has been mailed to the chief's office. That's been one of those things, if you're in the construction meetings, that's been hanging out there actually for a couple of years. Dr. Grimm has worked diligently on helping us get that. So Redbird Smith Clinic will actually belong to Cherokee Nation once the chief receives that and signs. Our cancer program received an award for it's called the Cliff Award, for their work on smokeless spent tobacco. That's a mouthful for trying to say it. So they're to be commended for a job well done. We saw a total of 91,028 patient visits in the Cherokee Nation Health Centers, and those are broken down by clinic in your packet. Our transportation services, I get lots of calls and questions about it, so I thought I would include that in our report as well. But they transported 154 patients, 10,013 miles, so that's a lot of work. And then our dental year-to-date visits, the total in FY12 was 37,028, and already this year we have seen 57,018. So Dr. Jones and his staff are to be commended for improving the access to dental services. So that's what my few notes I've had since you received the report. Do you have questions for me?
I have a question. I'll start off myself. Do we have a cancer coordinator specifically for cancer patients at each clinic? We had one at Redbird for one time on a 6-month pilot program, and she did a wonderful job, but they did away with it. They said she didn't have enough to do, so they reassigned her. Or is it just, can you shed some light on that for me?
There should be someone performing that task at every clinic.
It's not just the case manager that's over.
I think every clinic does it a little different. Like in Bartlesville, I'm sure the cancer coordinator is at Nowata because of the limited space primarily there. But I could send you a specific report per clinic if you'd like.
Anyone else have questions they'd like to? Councilor Lay?
Thank you, Madam Chairman. Dr. Grimm, is he here today? I just wanted to maybe get an update on that, the work that he's doing with Claremore to try to, with outpatient services, and when that might be done.
Yes, we got the numbers from the area office. We have it by county. We looked at North Tulsa, Rogers, and Craig counties. We asked the area for information on outpatient, CHS, and we have that broken down by Cherokee citizens only, and we have it broken down by all Indians. And we're waiting to go over it with the chief and any of the leadership that he'd like to have included to present that, and then we'll be ready to bring that forward to the council. But we have all the data now.
And do you have any idea of the time element on that?
Oh, I think as soon as we meet with the chief, we can move forward within the next.
And we talked about the inpatient the other day, which is actually kind of a hang-up for those folks north of 412.
The only place that we right now do the inpatient CHS are the counties around the Hastings Hospital that were historically in that Tahlequah service unit. The remaining counties right now, all we are running are the outpatient services. We have we've made a strategic decision to not go after the inpatient dollars until such time that we might operate Claremore Hospital. It's better when you have management of the facility, the inpatient facility itself, and the physicians that are referring from that location prior to taking over inpatient, because you have more management responsibility to determine what stays within your own facility and what needs to be sent out. So until such time as we were to operate that, we've opted not to go after inpatient CHS dollars around all the counties that would be within the Claremore service unit.
And that kind of leaves my folks in a predicament, you know, because we bump into that and then go through that catch-22 of Claremore. And so it's my understanding, and you correct me if I'm wrong, we talked the other day about these percentages, that Hastings folks get like 95% contract referrals. Is that about right?
It's across our entire system, we try to manage our CHS budget as a centralized budget. And we try to, on the outpatient services that we provide, we try to equalize that across all of our facilities and all of our counties. So whatever our percentage is for that across all counties is going to be the same, whether it's around the Hastings area or whether it's around the Claremore area. Where it differs a little is the inpatient referrals. And if you're in one of those counties that we control the inpatient, then you know, it's approved at a certain rate. If you're in the Claremore service unit, instead of coming to us for approvals, it goes into the Claremore service unit, and the only time it kicks out to us to consider covering is if it's gone through, you know, the denial process there and an appeal process within the federal government. And then we would look at funding it with the dividend funds.
And I've been told that the percentages are like 60% for Claremore area versus 95 for Hastings. And if that's incorrect, then you told me you didn't think that was quite true. But if I'm incorrect, I'll stand corrected.
Do you know what your approval rates are, percentage-wise, for your facility? I don't know that we can get that data easily, can we, Brett? For Claremore. If we could get that from George, we could try to take a look at how it compares to what ours is. And from an inpatient perspective.
The bottom line here is the folks that are affected by Claremore will never be served as good as the folks here at Hastings until we figure out a way to handle this. Would that be a correct statement?
I don't know if I'm willing to go on the record with that or not without studying it a little further.
That's okay. You don't have to. I'll do it for you. That's the way it is. That's the truth of the matter. And so I appreciate you working on this outpatient thing, but we've also got to think outside the box. We've got to get those denials quicker from Claremore. And I'm still trying to figure out that system. I guess you guys are still trying to figure out that system. Doesn't seem like it's a very smooth operation. From them to us or whatever the holdup is, I still get calls weekly. So we're getting better. I don't get as many calls as I used to, but I'm still getting calls.
I mean, we are continuing to improve and continuing to evaluate it. I know Brett and the CHS staff at Claremore talk. We know there are still delays in that process, and you know, anytime, as you know, I think any council person brings anything up, we try to deal with it, you know, immediately. That's not the best way to run things on a case-by-case basis, but we try to fix it immediately when we know there's a problem, and we're continuing to work on the process to try to improve it as well. I hope a year from now it'll be better than it is right now.
Yeah. As I understand it, at least the latest statistics that I see from Amy, we are going to spend over $6 million of the 5% through the Hastings system.
That's correct.
This year, 2013. And so that's $6 million that of the IHS money you didn't have to use. So where did that go?
I believe that money got spent this year too. We have a report if you'd like to see that. I'll grab my copy of it.
Well, it seems like to me, we diverted money from the 5%, and you didn't spend the IHS money that you used to spend on contract help for Hastings Hospital. Would that be a fair assessment, Amy?
Well, we have not, well, I guess this report, once I get it handed out to everyone, you can look at it and see that our expenditures have grown over the years on the IHS side. And actually, last year, we had a pretty significant over expenditure of IHS funds.
An over expenditure?
Yes, sir.
You spent money you didn't have, or what does that mean? I'm not an accountant. So.
It means that we did spend in excess of our budget for contract health on the IHS.
Where did the makeup come from?
It came from surpluses that we had on the operational side of things, and what I mean by that is all of our facilities in health have an operational budget. If they don't spend their full budget, those funds are all rolled together at the end of the fiscal year to kind of come up with a bottom line.
And where did those funds come from?
The clinics, the various clinics and other operational.
From IHS or?
Yes, IHS funds
Okay.
plus third party.
Okay.
Any billing revenue that we
So
collected.
did you take IHS clinic money from up north and take it to Hastings then?
Not necessarily.
That's what it looks like.
Well, the way it works, sir, is at the end of the fiscal year, the accounting process, they do a closeout. And every IHS accounting unit is rolled together and they look at total revenues versus total expenditures. They don't necessarily do a closeout for each individual program within IHS. So we've been able to, rather than in the year in the red on the contract health program, we're able to use the surplus from those other programs to offset that. We did not give a directive to the clinics to
If
halt spending.
you live where I live, you would say that you took money from clinics up north to fund WW Hastings. Would that be a fair statement for me to make where I live?
I would say that the surplus, the unspent funds from all of our programs.
Exactly.
Regardless of where they are, whether they're north, south, they're in
I
Tahlequah,
understand.
the surplus went to cover the over expenditure in contract health.
Okay.
So the 5% fund, at this time, the majority of the funds that have been spent, how much is left in that fund, by the way?
Let me refer to this report that I just handed you all. The very top section, you would ask in your email, Mr. Lay, for fiscal year 2010 through current.
And it'd be nice to have this stuff before we get to committee meeting. I asked for that to happen. It's never happened with health.
I apologize. That's my fault. I didn't finish preparing this until right before our meeting this morning, so I haven't emailed it yet, but I will. Across the top, it shows how much was allocated by funding source for each fiscal year for our total contract health program. We have multiple programs that are funded through tribal funds as well as our IHS funding. And then, of course, over on the columns that denote FY13, those are our year-to-date obligations. And basically what that means is how much we've approved for services. We make an estimate in the system to the best of our knowledge of what that service is going to cost us. During the fiscal year and closeout process, we make some adjustments based on our historical percentage that we end up paying for services and all these other different types of adjustments that we can discuss if you'd like, or we don't have to. It's up to you. But anyway, these are the preliminary numbers right now. They will be changing as part of the closing process. But at this point, you can kind of see where the balances are. And we have obligated all of the 5% money.
And that was about 12 million.
It's 13.
Yeah, 13. And, okay. And over 6 million was spent at Hastings this year. This
At the
fiscal
bottom,
year.
at the bottom half of the worksheet shows of the total represented above in the actual column, what percent of that pertains to just Hastings. So like in the FY13 column for CHS dentures and eyeglasses, we've obligated $213,000 at Hastings, but the total that we've obligated across the system, if you look above, is $927,000. And then those percentages beside those numbers for Hastings represent what percentage of the total budget was spent at Hastings.
And how much IHS money that was dedicated for Hastings
We don't,
went into contract health?
when you say dedicated for Hastings, I don't know if I'm going to answer this correctly. I'll try. We do not denote within our budget. We have one big contract health budget for IHS, and we do not specify how much is for each facility.
Okay, how much contract, IHS money for contract health referral was spent through Hastings?
Spent through Hastings, it would be, for IHS, it would be the $8.3 million at the bottom part of the sheet there.
Okay, and how much of the 5% was spent through Hastings?
That one is 5.6.
About 14 million.
Say that last part again, Dick. I didn't hear the question or what you said.
IHS money spent for contract referral through Hastings, 8.3. And the 5% spent through contract referral through Hastings was how much again? 5.6?
5.6.
5.6.
The 5.6 is the dividend
Yes.
that was going to Claremore.
It's
Big
not
spend
going to
at
Claremore,
Hastings.
it's going to Hastings. Okay, thank you.
Next is Counselor Keener.
Thank you, Madam Chair. I was going to ask the same kinds of questions, but most of those were answered. But on the accounting units, we have 5 total accounting units for the whole healthcare system, or these major ones shown. Is that correct? Yes, sir. Okay. And so this is very helpful to see this right now. And I'll have more questions later on that.
Okay.
too. But I did want to say that I know healthcare is a major concern for us, so everyone. But over the course of the last month, I just wanted to thank Ms. Davis and Dr. Grimm for all the work that you and your staff have done, because I know I get the calls as well, and I'll call and need help for someone. I personally cannot give medical care or attention to anyone, so I appreciate you being there and finding answers to difficult questions for all of us. Thank you for that.
Thank you.
Thank you, Madam Chair.
Counselor Kara Kelly Watts, you're next.
Thank you, Madam Chair. So from what I could determine, at least based on this month's report, is that only 33.5% of the overall patient load that would be eligible, I assume it would be eligible because they got forwarded to the committee on the files for Claremore, is 33.5%. And then for us, through the regular contract health service that Fred administers for everyone under the Cherokee Nation CHSDA for contract health, it's 97.7%. That was $3,205,010 for 6,381 cases. But under the 5% dividend, 204 of 319, or 63.9%, were approved, but there's another 112 pending, which could likely be, according to your prior reports, would likely be approved, which would put it more like at 99%. But if we're only looking, because of that approval process, that there's further information needed and stuff, we don't really know unless we get a cumulative report. So that's what I was wanting to see. to maybe understand better.
We can bring a report that does like a follow-up.
And I
on-
didn't understand.
Because I think what you're looking for, if I understand you, Watts, is you'd like to know next month of those 214 that are still out there, where are we on getting those approved as
112.
well?
Yeah.
Yes.
And one of the misunderstandings is that just because something's done through the Hastings financial system, they may live well north of 412. That we have people from Nowata that go through there on surgeries. We have a lot of things come into Hastings through our system. So.
Well, and I think that's because of the divide between being served by Indian Health Service versus being served by Cherokee Nation, that our folks are willing and feel like they're forced to drive to Hastings to be served by the tribe rather than the federal bureaucracy.
Right. And if it's a referral that needs to be done, but we can do it at Hastings, we're going to try to route that through there first as a
The only thing
last resort.
that I couldn't, and this would be for George, is what are the 168 CIH clinics that are being reported in your report? That was something new I caught, or
Those
newer.
are-
What is that CIH clinic?
Patients who receive referrals, but the referrals were rerouted to internal clinics because they can be handled within the system. They weren't sent out to specialists.
Okay, so that changes how you look at your numbers then, I would think, because that means that they were cared for and their medical need was met, right?
Correct.
So that means if there's 521 cases that are funded and 168 cases that are referred internally and addressed, then that would increase that number. But I don't know that, I mean, we're still looking at probably 50%.
8%.
You already have the numbers worked up over there?
8% was denied.
No, so this is under
Deferred.
Claremore Indian Hospital, page 2 of 2. The 521 cases were funded, and then the CIH clinics, the 168. He's saying those medical needs were met, but they were, instead of going out, they more effectively used their money by referring them in to an existing service. So it'd be 689 out of 1554, whatever that is.
But the deferred isn't saying no.
Yes, it is in IHS. It effectively means no because they're deferred. They'll go into medical bankruptcy and then maybe they will get paid eventually. That's the reality of that.
It's almost a death sentence.
See,
Is it?
the denied, if I may.
No, please, George.
The denieds and deferreds are all entered in, and that's what Brett's staff pull off and re-review for the Cherokee Nation program. And those should be done by the end of the week after the review on Monday. So I was kind of shocked to hear that we were having a problem with that in council last. I didn't realize that we were having a problem.
Madam Chair, I have additional questions from the reports, but I know we're on this kind of one subject. So, well, I guess my one last question on this subject is that I know I'm familiar somewhat of the process, whether I like it or not, what IHS does. But in the end, even after all these discussions, I can't give my constituents any kind of idea of the process or the timeline it takes when I know that they have to go and be denied by Claremore Indian Hospital. And there may be additional time added to that if they're referred from one of our clinics to Claremore Indian Hospital to be denied, so that may add additional lead time. But then once they're denied, what is our time frame expected? And Brett, maybe you have this. I know we had a flow chart, but I didn't have time expectations on the flow chart.
It's within, we reviewed, we roll that process once a week, so, within 7 to 10 days, we're looking at that, so.
But they review theirs on Tuesday, if I remember correctly.
Tuesday, yeah.
And then we try to pick those up by Friday.
Yeah.
So I know, I've invited you and wanted to get those questions answered at that upcoming town hall. So if we could have some handouts for people that would help, like that flow chart and such. And I know George is committed to being there too. they're gonna have these kind of questions, and I wanna limit it to policy and procedures so that we don't get into medical situations for individuals in front of a crowd. But these are the kind of things, I don't know if you wanna answer, but on the 800 online pharmacy folks we're serving, what's our potential number? I know it says 800 have already signed up, but what's the potential number we could get signed up probably?
I don't know if I can answer that because obviously it depends on who had access to the internet. Jeff, do you?
What do we expect? What do we expect, I guess, when it's at full capacity?
It'd be nice if everybody signed up that way. I mean, it's capable of doing it. But right now, I think, the internet access and usage is increasing. And I hear really good things from patients who are using that because it is very user-friendly. It's a lot easier to input all of your numbers over the internet on the computer than versus trying to type them all in by the phone. So in the end, I would like to see about a 60% usage, 70% usage rate for that system if possible.
And remind me, I know you give the numbers, but how many prescriptions do we fill today?
Typically, we'll probably fill around a day or a year.
A year.
A year. We'll probably fill close to 2 million this year.
Okay. That's a lot. So that's 60% of two. Okay. Very good. Well, thank you guys. Thanks, Madam Chair.
Counselor Joe Barth, you're next.
We go over this, seems like every month, about Hastings performing, Claremore not performing. And it's very clear when you're dealing with the bureaucracy like Indian Health Service or the Bureau of Indian Affairs or HUD, you get into that. Now, what have we looked at solutions on how we can have, George, have you looked at how we can, where they're always talking about Hastings 90%, 95%, you guys are batting 60% over there. Have you looked at how you can improve your system?
On our contract health system, we're pretty much limited by the funding we have. Now, I thought we were going to come along with a pretty seamless solution here when the 5% money came and Brett and I sat down and put a system together that would streamline those referrals and those denials and defers through our system on back into the Cherokee Nation system.
Sure.
And I thought that would get them back in and re-reviewed back into that 95%, 99% approval rate. But as far as our approvals and denials, we're always going to be based on that funding level.
Yes.
We're going to always fall back to that. Of course, I have a better answer for you, so.
I kind of know the answer before I asked it. I just,
Yeah.
because, we dealt with this years ago. I mean, we've been doing this for a long time. But I thought we had made some headway by now, but it looks like we had a solution. It just didn't come out that way.
No, we, on page 1, you see we get, last month in July, we had over 600 new and reactivated patients.
Yeah.
And we average that every month. We have averaged it every month since I've been there, and I've been there almost 5 years now. We have received 0 increase in funding. And this is the way of the times here. Patients keep rolling in, and we get no more funding for it.
Yes. Well, I'd like to commend the staff at Hastings for doing a good job. I mean, I don't want to fault them because they're performing. Then we have a bureaucracy we're dealing with here on the other side. So,
Well, it's an ongoing challenge. We're growing by 10% per year in increase in volume. And I'm sure Mr. Valier sees the same kind of challenge. And with that, comes an increased demand on our contract health system. So, I wouldn't be surprised if next year we may have to unfortunately report, because the funding has been cut, that we're only approving 80% of those referrals because the demand is going to continue to grow, but the funding for contract health is not.
yeah.
And it comes to where we have to make very difficult decisions on what we can do, and that's why we'd really like to pull as many specialty services in and do it ourselves as far as we can through a partnership with another entity, whatever we can to be creative in providing the service. And then, of course, improving our collections, because
Yeah.
we've got to do better on that,
That
more
makes
so
sense.
than ever.
That makes sense. Thank you, Madam Chair.
Thank you. Counselor Buzzard?
Well, I think, I just listened and heard a lot of the questions that I had already been answered that the other counties have asked, but I guess just a couple of questions with George. Can you report how many Cherokees get a referral out of Claremore?
Yes, sir, I made that note when we were
Okay.
asking about the percentage. I made a note to break it down by tribe.
Okay, and the other thing is what I'm hearing is the approval rate is not nearly as good as what it is at Hastings.
That's
Is
correct.
that right?
That's correct.
So what I'm hearing now is like about a 95 or 96% approval rate at Hastings. And then up to Claremore, it's around 50 to 60%. Do you know why that is like that? Do you know why? I'm sure you don't know why, but you might.
Well, we have it's going to be, the biggest reason I can think of is just lack of funding. You know, we have so many patients and that funding per week is only going to go so far. And sometimes we can fund 100 patients, depending on what cases we have. Sometimes we can fund 250. It just depends on what they are.
In this report that you're giving us, George, is that the overall patient load at Claremore?
Yes.
Okay, so you're not breaking anything out by
tribe.
Cherokee load at all? Would that be difficult to do, to break it out by Cherokee? I mean, this is a good report you're doing, but I think what we're interested in is Cherokee.
On some things, it might be, the contract health, shouldn't be that hard to do
Okay,
that.
I'd like to see that.
Okay.
Thank you, and I have one more for Ms. Davis. I asked for this report here, and I'm not sure what this report on the last page is telling. What is it? What's it mean?
That's the location of the referrals we review through Claremore. And that's a hand tabulated.
Okay,
So,
this
yeah.
is what's been approved out of Claremore.
Right.
Is there a way to give us a report on what is approved out of Hastings? Can you do that?
I don't know, that's, I did that by hand. So, I mean, with check marks and, so that's, and
This is
from
good information.
from a size point of view, Claremore and CHS referrals we see monthly relate to about the size of the J Clinic. And from that, we take then the ones that, you sort out the non-Cherokees, which are a pretty good number, and the ones that live outside of the 14 county, and that takes it down to about the third of that number. So that's where that comes into play.
Yeah, that's good. I like this report. At least it tells us where people are. Okay, that's all I have. Thank you.
Thank you. Counselor Fishenhock, you're next.
Can George talk to us about these deferred, or Brett? They're get sent to you, right? Okay, talk to me about the 738 deferred cases.
Well, there's a handful per week that are deferred for lack of good information. Like somebody that needs a sleep study, it's got to meet medical necessities. So if it says daytime, sleepy during the daytime, we need to see, for Medicare-like purposes, you need to see, I'm using this example because I dealt with the, obesity, sleep apnea, we need to go through a few more hoops to meet that necessity. Now, the other ones are the call-ins. When somebody has an emergency, we're not going to look at it until we have the medical records, and that's 30 days plus after the fact. And that's the majority of them, because that's the referrals that George's group sends out. They're in there. They enter the referral, or we help them get the referral to them, and then it's in the note every time it says patients advised to get records within 30 days. So,
What percentage would you say that Hastings is deferred for the same reason?
we don't use the deferral category. So if it's an ER call-in, we actually deny. We send out a denial first, and then that patient sends back they appeal it. it's an appendix category at first.
Okay.
So then they send back, we send out an appeal letter, a form for them to fill out, and then they attach the records.
You all automatically deny it, and then we start the appeal
Well, it goes into
process.
pending status at first, but it's not approved at all.
Okay.
We're not going to approve it until we need to rule out, all the exclusionary type things.
Okay. Next month, are you all gonna have, like you do with your other charts, a year-to-date
Yeah. I mean,
on
that's-
that deferred category?
Yeah.
So we can keep up with it and see what the percentages are running. That would help us out a lot. The other thing, I guess, is a question for Amy. Back to this chart, Amy. Between fiscal year 12 and 13, it went from contract health services, went from 13 million to 8 million. And at the same time, you just now said 5 million went to contract health. And that 5 million's lining up with the contract health monies we set aside, the dividend. Is that what we did?
In FY12, when we first got the dividend money, if you look at the FY12 numbers at the top of the page, if you notice, we had quite a bit of carryover on the dividend money for FY12. And the reason that over expenditure that's on the IHS side, we were kind of during a back and forth period on what were the rules for the dividend money. Because if you recall...
Asking the rules, did you all simply take the $5 million and pay it on that? That's what I'm wanting to know.
We did not. What we did was we were operating under the legislation in FY13. FY12, if you recall, Health had drafted a policy that was pretty restrictive. Do you recall the policy that I'm talking about? Where the funds were to be used only for Claremore patients. And we were only able to spend $889,000 worth of those funds in FY12 under those rules. And we were, there were some conversations about the policy was more restrictive than the legislation. And at the end of the fiscal year, we went ahead and closed out with everything as it was. And then beginning in FY13, it was determined, and I believe we all discussed it in committee, I believe, that the legislation, we were going to go by the legislation, which said it was for all Cherokees, and so that's how we've operated in FY13. So essentially, those funds were available for all Cherokees regardless of where they received their services.
Okay. That's simply what I wanted to know. Okay, so the 13 million in FY13 makes up the dividend plus like the airplane sales and...
Yes, and the carryover from the previous year.
How much was the carryover? It wasn't
I think it was about
100,000?
500 and some.
Yeah.
Maybe it was closer to maybe it was 6 million.
Okay. Okay, the second thing is, the contract health, the substance abuse treatment,
Yes, ma'am.
fiscal year 2012, we overspent.
Yes, the situation with that one is the money comes to us through a 2% surtax on alcohol sales at the casinos. And what had happened was, or the way it works is every year budget time, I contact Sharon Swepston and she tells me what they're estimating to collect and that's what we budget. Well, of course, that's an estimate and the actuals that come in are different than that, and we had not done a reconciliation. And basically what had happened is the money that was coming in for substance abuse was greater than what we had budgeted. So we had a fund balance. And at the end of FY12, we were overexpended, and I contacted our accountant who works for Lacey, and we discussed this, and because there was excess money there, we determined rather than try to move those expenses to a different funding source, we would just leave them there because there were funds there for that purpose to cover it. And that's why the budget is so much higher in FY13, because that's the accumulation over the years of that surtax, the amount that we had not spent. So of course, going into 14, the budget's decreased because it's just the 1 year's allocation.
That's what I was wondering about.
Yeah.
That's fine. Okay, I was going to wonder what we was doing in 14.
Yeah, it's around 200, I can't recall the exact figure, but it's around 200 to 250 per year.
Okay, that's what I was wondering, if we was just estimating it badly or if there was something that was catching up.
Yeah, it was a
Catching
catch-up.
up. Okay, thank you.
Madam Speaker, you're next.
I think this question is probably for Connie and for Dr. Grimm. Once we get the contract health issue for outpatient folks at Claremore resolved, and this is what Dr. Grimm, the project Dr. Grimm is working on. If we get it resolved favorably, where we take over the contract health for outpatients, that will mean that all of those folks will come directly to our system, right?
Yes.
That's when everything will work in a seamless way for at least a majority of what's happening at Claremore. Is that correct?
That is our hope.
So, do you think in the next 30 days we'll maybe have that
I think so.
answered?
We'll have it answered, and then it'll take approximately 60 days to get it worked out with Indian Health Service to get a contract, if that's how we move forward. And I was going to point out, too, as we've been having the discussion, you know, when we say 90% or 95% approval at Hastings and 40 or 50% at Claremore, that 95% is really across our whole system, not just around Hastings or Tahlequah. It's for all the northern clinics. It's for everyone that comes through the Cherokee Nation Contract Health Services. And what doesn't come through there are the inpatient people at Claremore. And then, Councilor Buzzard, on your question about those graphs on the last page. So the Cherokee citizens that get denied there were, in this month, July, 319. We have already approved 204 of them, and we're looking at those 112 that are pending right now. So, you know, we're at a 66% approval on those that were already denied at Claremore, and we will likely pick up a lot of that 100 more patients. And that was a report that I believe Councilor Watts asked if we could carry forward and show in future months what we're doing. So, and then when we do pick up Craig County, and when we pick up North Tulsa and Rogers, if we pick those up for Cherokee only, then a large number of people will fall under us immediately and won't go through this. It would just be the inpatient referrals that would fall under Claremore still.
Thank you.
Counselor Thornton, you're next.
Yes. How you doing this evening?
I'm great. I had a good morning. How are you?
I'm doing good. So that's good. I asked for this on page 20. I asked for this chart to be coming into effect every month.
Which
It's
page?
a 5% Cherokee Nation Health Services funding, how it's distributed, and the communities. And it's gone by month. Every month that I've looked at it, that I've gotten it, either Veneta or Claremore are the ones that get the most out of the 5%. And I don't know if I'm reading it right, but then you go down to Chelsea, Catoosa, Collinfield, Pryor, Owasso, and everything else is north of what I call the Mason-Dixie line. And, you know, Mason-Dixie line to me is Stan Wadey country. And I hadn't seen anything down there much at all for them. But that 5%, when it was procured, it wasn't procured just for Claremore. It was for all of us. And I hadn't seen a lot down on my end of the spectrum here. And I just want to make sure that everybody realizes that. This isn't all going to Hastings or down to Redbird or over to Muskogee or over to Stillwell, because I hadn't saw those names on here. And I want to make that clear. Thank you.
You're welcome. Okay, I think that's all the people down for questions, and
I have one.
oh, I'm sorry, one last question, Councilor Lay.
Where'd Brett Hayes go? Brett, this chart that he's referring to.
Yes, sir.
Is that, I don't see Tahlequah on here.
Well, that's part of the,
Sallisaw.
since we started this, we've had the Claremore referral process is its own little,
And that's what I want
That's
to
what he's
make
referring to.
clear to this counselor is that the Hastings area communities, I don't think are in this, on this chart.
You're correct, they're not.
There's another chart somewhere you're not.
I don't have, we don't chart that because as it's.
You
I
don't
know if
chart
it's-
that because you're getting 95 and 96%
Well, it's,
out of Hastings.
this is a hand, we do this one by hand because that's kind of
I
the,
understand.
okay.
But this chart does not take in the Hastings area network.
Yeah, but something you have to realize, it takes in the northern side also. And it also is what you're talking about. Hastings,
Well,
Hastings is a
if I'm sitting
Cherokee
here,
Nation
if I'm
facility.
sitting at 50% and you're sitting at
Claremore's not a
95,
Cherokee Nation facility.
I don't care about Claremore. If
Go
if
into
my
it.
people are sitting at 50% and yours are at 95, forgive me, that's not a
You're
fair deal.
95 all over, not
That-
just
that's
95
not-
in my district.
The number that comes down to Hastings from my country is a very
It's coming
small
from 95
infinitesimal
all
number.
over.
And the fairness issue,
One place, that
Mr.
is a
Byrd,
Cherokee
is what I'm referring to when I bring this up every health committee meeting. We don't have fairness,
Look like me.
and that's a fact.
That's right.
Thank you.
We may not at this time, but we're trying to attain that goal. If
Well, we can't get it
we're working on it, and as Madam
until-
Speaker said a while ago, if this all works out,
Well-
eventually it's going to be
All
better.
right, once we get to the outpatient, Dr. Graham, then we've got inpatient. How many of those are there and how much will that take you?
I'm not sure we don't have it broke out by, we can potentially get you some rough numbers on budget.
Appreciate it. Thank you, man.
At Claremore.
It's a start.
I've got one other thing. I'd like for Jeff Sanders to come up for just 1 minute and give us a little update on something we've all been looking forward to on October the 1st, that we are looking forward to, and the patients, which is 90-day prescriptions.
Absolutely.
I don't know how happy y'all are about it, but we're very happy. So explain it to us a little bit.
We are, October 1, we're ready to go. I think most of you guys have all seen the policy, we can call it. It's really more of a guideline for us to implement the program. Most of our sites, everyone's aware, and from this point forward, October 1, we're going to start the program. Patients can begin requesting 90-day prescriptions through their providers, and we'll begin filling them as those orders are sent to the pharmacies.
And the physician
As they, right.
they can say.
Councilor Watts?
Thank you, Madam Speaker. I'm still not necessarily opposed or for it. I'm just always interested in what we're doing. But there was a constituent that actually works in Indian healthcare who emailed me a couple of very interesting journal articles show that we should not be issuing 90-day prescriptions except for a limited
Number of patients.
number of patients or just certain types of prescriptions and such. And then it's medically a negative. It's setting us up for failure in terms of serving them. So if the Affordable Care Act and DHS funding is based on comparative effectiveness research or patient-centered outcomes, which translation, it needs to be evidence-based practices that are proven to be supported by medicine or research, then how are we going to have somebody to reimburse us for this if it's going against what appears to be the technical practice of the time?
That's where the provider, it's the responsibility of the provider to make the judgment whether I can safely receive 90 days medication versus, possibly an 80-year-old non-compliant diabetic.
And it did seem like the new
Correct.
policy was leaning a little bit toward that, but I wanted to make sure we were still in that direction. I couldn't remember what the last email was on it.
I sent 2 policies and I think I only received 2 comments on the two policies, and they basically are the same thing, that we will provide the 90-day prescriptions as the physician or the provider feels like the patient can safely receive, in compliance with all the federal regulations that, you know, we can't dispense narcotics without the patient going and seeing the doctor, and, you know,
Correct. There's safety concerns
medications
and-
that have to have monitoring weekly, so.
Thank you very much. Thank you, Madam Chair.
Madam Chair, just a comment.
Well, I've got one before you. Counselor Taylor.
Will you be classifying the drugs? Certain drugs can go on the 90-day prescription, certain drugs cannot, based on their classification?
There are certain medications, classifying an entire set of medicines, probably no, but based on the individual medications themselves, and I think as you probably look through some of the procedural issues in the policy, most of those are related directly to restrictive medications. I think we did make mention of behavioral health concerns, and there are certain medications that certainly patients shouldn't take a 90-day supply home of because they can be potentially fatal in an overdose. Warfarin would be another example of medications, you know, that we're not going to be able to dispense 90 days because of frequent monitoring. So there are medications that have narrow therapeutic indexes as well, which require frequent monitoring, or wouldn't take a lot of medication for a patient to get themselves into trouble.
So it's more of a case by case?
Yes, it's up to the providers, and you know, quite honestly, it was 3 years ago we had the same program. You know, still the providers were driving the process of ordering prescriptions for patients, and those that were eligible for 90-day dispensing certainly received them. So.
Well, I might comment, it worked well for many years, 90-day prescriptions. I think it will again. Counselor Buzzard?
I just want to compliment Mr. Davis on the insurance. I hopped on that for several years about insurance, and I think we're going to see an increase. A large increase. Anyway, thank you.
Thank you.
Okay, I think we're about finished here, and thank you, Connie, for that. Now we're down to old business.
I'd like to move that for next month.
All right.
Good, please.
We'll move that.
Second.
Okay, all in favor of forwarding this to next month, let me know by saying aye.
Aye.
Any new business? We have none pending. And the next meeting is scheduled for Monday, October the 14th at 1 p.m. And hopefully we'll get started on time if we can not have such hearty appetites and take so long for lunch. Should I have a motion for adjournment?
Motion to adjourn.
All in favor of adjournment, let me be somebody saying aye. Aye. We're adjourned. Thank you, everybody.